Qualitative research. This is my other hat. I have been a qualitative researcher for almost all my research career, which, as you can see by my grey hair, is a very long time. So really, I think because you've got kind of a mixed level of knowledge, you know, some of you have a certain amount of experience in qualitative research, but some of you it's completely new. So this is really the basics. What I'd like to do is for you to just interrupt me with any questions as we go along. Just ask me anything. If there's anything that you don't understand or anything you'd just like to talk about a bit more, you know, just shout, and that's what we'll do. Okay, so this is what I'm planning to cover. So just some real basics about what qualitative research is and why we would use it. What are the benefits of qualitative methods rather than any other kind of methods you might use, and you know, what it's used for in healthcare research generally. Then I'm going to spend a bit of time talking about interviews and focus groups, because I think those are the most common methods and the ones you're most likely to use. And then we'll talk very briefly about how you find a sample, how you do your data analysis, and how you write up qualitative work, because this is different from any other kind of aspects of research that you might have come across before. And I'll try to use illustrations from my own research work, just to show you some examples of how this all works. So I should probably tell you just a little bit about the kind of research I've done. I was a primary healthcare nurse, a community nurse, and my interests are in long-term conditions. I also worked for quite a long time with Aziz Sheikh. I managed his allergy and respiratory research group for some time, so we did some research together, and one of the studies I'm talking about will be one of those studies that Aziz and I did. I did some palliative care research. My own PhD was about the differences between how social workers and community nurses treat older people on their home visits. So I'll be talking about all those sorts of things as we go along. Does that sound like that covers the sorts of things that you might want to know about? Yeah, good, okay, good. And I can always add a bit in if there's anything you think is missing. So what we're talking about when we're talking about qualitative research is to try to get some kind of understanding of the experience of the patients and their families and the health professionals that we work with. So qualitative research is all about understanding context, how people live, how they view their illness, how they react to their diagnosis, what's their experience of treatment, how they manage a long-term condition, how they make decisions about their treatment and care. And we might also be interested in how health professionals behave, so why a GP you know, implements their care in a particular way, what people's beliefs are, and that includes health professionals as well. So the study that I'm going to use as the main example is the study that Aziz and I did about anaphylaxis in teenagers. So we were particularly interested, and we know we have a problem in this country with nut allergy, which is, you know, reactions, anaphylactic reactions are very common in teenagers. So we know that they're an at-risk group, but we don't really know a lot about how they manage their condition, how health professionals manage their condition, and crucially we wanted to know what we could do better to, you know, prevent teenagers having these life-threatening events. So that's the sort of thing that qualitative research can do. You know, we know, for instance, that teenagers carry EpiPens, the anaphylaxis, you know, their medication, but they don't tend to use it when they have an anaphylactic reaction. So, you know, what can we do to make it easier for them to use their their EpiPens when they're actually having a reaction? Well, if you want to know, you have to ask them, you know, what are the problems you face in managing this? Why are you having these reactions? Why are you not avoiding the foods that are harmful to you? Why don't you use the treatment that we've trained you to use when you're in an emergency? So, you know, you're never going to get the answers to those sorts of questions from a questionnaire. You're going to have to try and do a kind of in-depth interview to try and drill down into what they're thinking. So qualitative research also helps us to understand how people make sense of those sorts of situations. And it was very similar when I was doing palliative care research. You know, it's how do people react when they're given a diagnosis of a life-limiting illness? You know, how does that affect their lives, and how does that feeling affect their treatment and their care? Now, there's something that I need to try and get across to you about qualitative research that's really important, and that's this last point about how the researchers and participants make meaning together. If you're sending out a questionnaire, then you send out the questionnaire and you get your answers back, and there's no kind of dialogue around that. But qualitative research usually involves some sort of conversation between you as the researcher and the patient or health professional that you're interviewing. And it's how you explore all these complex concepts that I've talked about that makes the meaning of the situation. So it's very different. You know, your interpretation is dependent on what people tell you. That's dependent on your skills in drawing people out to tell you these important things. So we'll try and cover all that as we go along. So the sorts of questions that qualitative research can provide the answers to are these kind of why questions. Why do people behave the way they do? What's an individual's or a group's perspective? We'll be talking about focus groups a bit more later on, and I'll try and distinguish between those methods for you. How are people affected by an illness? Process is an interesting one. Sometimes if you're looking at a healthcare system, you might be interested to understand, well, how has a situation developed in this particular way? So one of my PhD students, now qualified, Catherine Cresswell, who you will probably come across at some point, did a study about the use of electronic health records in hospitals in England. And it was a horrible situation where this new electronic health record was supposed to replace all the paper records. And health professionals did not like this one bit. And that was partly because the technology wasn't as good as it should have been. But really, you know, she wanted to understand how it had got to this situation where people were kind of being forced to use a system that they didn't like. So process those kinds of things. You might be interested in differences between social groups. So that might be differences between men and women, or different age groups, different ethnic groups, different socioeconomic groups, and qualitative research can help you to understand that. An interesting one in relation to clinical trials is about whether an intervention works or not. Well, a trial can tell you, but it can't tell you why. So there's some very interesting research where qualitative methods are embedded within a clinical trial to try and provide some kind of explanatory data. So the example I've got in mind is not one of my own studies, but there was an interesting study about pain management. People with chronic cancer pain were given an educational intervention. So they saw the nurse every week for 10 weeks, and they had some education about self-managing their pain better. And the quantitative measures, sort of pain questionnaires and things like that, were very difficult to interpret. There were some enormous differences kind of within the patient body about the effectiveness of the intervention. So they did some observational work to try and find out what was going on. And what they found was that the nurses were being good nurses but really bad researchers, because they were tailoring the intervention to every individual patient and what they thought of them. So the intervention wasn't being applied consistently. So that's just an example of how qualitative work can help to understand those things, you know, and communication as well. You know, we can use a trial to measure how many people stop smoking or something as a result of an intervention. But the qualitative elements will tease out all those factors that contribute to success or failure. Now, the important point on this slide is not particularly that qualitative and quantitative methods are different, it's that they complement each other. They shouldn't be seen as opposing. So, they just address different things, they answer different questions. So what we're doing is exploring a phenomenon, usually trying to describe, understand, or explain something. And these what, why, how questions, not how many or how often. That's something completely different. And qualitative methods can be standalone studies. So most of my own work, qualitative work, has been standalone studies. But as I said to you before, they can be embedded in a trial. Or what you're seeing more and more often now is mixed method studies, where questionnaires will answer some questions for you, but you might need some qualitative methods to explain your findings. Or you might do some exploratory work using qualitative methods that you can then use to design a questionnaire or something later. So, with qualitative work, we're looking at depth rather than breadth. So you will have a smaller number of participants. And this is one of the things that I think people who are trained in quantitative methods find a little bit difficult to understand, that you might have 20 or 30 participants in a qualitative study that's going to give you a mountain of data like this. But it's not like a questionnaire where you might have 200 or 300 respondents. But the data is much more detailed and rich. And that's really partly why we need smaller numbers, because if you did 300 interviews, your data would fill this room and you'd never manage to analyse it. It would just be too much. It's much more flexible and open-ended than any kind of quantitative research that you've done. So, once you've got your questionnaire, that is your questionnaire. You've piloted it and you've revised it and refined it, and then that's it. But with qualitative research, when you're interviewing somebody, they might come up with something that you'd never thought of when you were planning the research, but it seems like it's a really pertinent issue for you to explore with other people in your sample, so you can then add questions about this new information that you found along the way. We also tend not to set right at the outset a fixed number of participants. I'll talk about sampling a bit later on. But we might set out with the idea that we will interview 30 people for our research. But if we interview 30 and we still have some unanswered questions, we might interview a few more. If we interview 20 and decide we know everything that it's possible to know about this particular topic, we might stop there. So it's a little bit more flexible and open-ended in that way. And the key to it all really is this interaction between the researcher and the participant. And I'll talk a bit more about the skills you need for that later. Now, because it's quite personal in that way, this kind of interaction that happens between you and the participant, you need to be really transparent in what you do. So when somebody reads your PhD thesis in 3 years' time, so they need to be able to see how you've reached the decisions that you've reached. And that they can understand how you've interpreted your findings. And it's really important that you kind of keep an account of that. And we talk about the concept of reflexivity. Is this something that you're familiar with? Or some of you that have done qualitative research will know about this. It's your ability to look at yourself and think about how you might be influencing the interaction. So an example of that is, as health professionals, we are trained in a certain way and we have a lot of knowledge. So we might see somebody who really ought to give up smoking, and it might be quite hard for us to understand why they don't. So we have to look at our own judgments about these things, and just think about how that might influence how we ask the questions. Or sometimes people are very good at telling us what they think we want to hear, especially when we're health professionals. So, you have to kind of reflect on that and try and find ways to, you can never eliminate bias, but you can kind of just be aware of where your own biases might lie. So I'm a bit anxious about saying this in the era of Donald Trump, but you know, we're not sort of necessarily looking at one truth. We're looking at different perspectives on a situation. So a lot of the research that I've done takes more than one view. So when we look at teenagers at risk of anaphylaxis, we interview the teenagers, we interview their parents, and we get a different set of views of the same situation, and we interview the health professional that looks after them the most closely for yet another view. And it's how you bring all those views together that gives you some sort of sense of a whole picture rather than an absolute truth. I'll talk more about analysis later, but it involves identifying themes from your data. So you'll look across your whole data set and try and find the common ground between your interviewees and also the differences. But it's open to things that come up along the way. As I said, if somebody publishes a new paper while you're in the middle of your data collection, they might have a really interesting idea that you want to ask your participants about. Or as I said before, your interviewees might come up with something that you want to pursue. And what we put out, our analysis, our writing up, is our interpretation of what our participants have shared with us. So I'll try and explain that more when we get to data analysis. Now, I don't want to bamboozle you at this point. This is where it gets a little bit theoretical. It's one slide and then I'm going to move on. But you just need to know this. And particularly those of you that are doing qualitative PhDs, you will need to engage with theory at some point, because it really influences how you approach your whole research. So qualitative methods are based in the social sciences. And that's a very different discipline, particularly for those of you that are medically trained. Because they draw on their theory from anthropology, philosophy, and sociology. Now, you're not going to become experts on any of those things in 3 years, even if you should want to be, but you just kind of need to be a little bit aware of the differences in approach depending on where you come from. Now, I would consider myself, if I had to pin it down, as an ethnographer. I don't really like being labelled, but that's kind of where most of my research is. Now, ethnography comes from anthropology, really where researchers used to go and live with a particular group of people to try and embed themselves in their way of life and gain an understanding through that. So when I was interested in what district nurses and social workers did with older people in the community, I'm not going to go and live with anybody, but I am going to go and observe what they do in real life. I can interview them, and they will tell me how they go about assessing the needs of an older person in the community. But that might be different from the actual reality. So if I want to know what's really going on, I need to go and watch them as they interview an older person. And of course, you won't be surprised to know that what they said they did and what they actually did were quite different. When I was interviewing them, they would tell me all the right things that they should do, how they respect the older person's right to decide how they're going to live their life, and there's an autonomous individual. When they went in the older person's home, I didn't see a lot of that. They started off okay like that, but then the older person would do something or say something that the district nurse thought was dangerous. So for instance, one example that springs to mind, this elderly lady was quite arthritic, and she had her telephone by her chair, and there was a long telephone wire trailing all the way down the hall, and every time she wanted to go to the bathroom or the kitchen, she had to cross this telephone wire. So of course the district nurse looks at that and sees risk, falling, and she must have spent half an hour trying to persuade this old lady to move the telephone back down the hall, which would have meant the old woman, every time the phone rang, would have had to struggle to get up, walk down the hall, answer the phone. Didn't suit her one bit, but there was this kind of conflict. So I would have never found that out from interviewing the district nurse, but I could see it with my eyes, and there was a lot of that kind of thing went on. Phenomenology, I'm not going to spend too much time talking about that, but it's really about how people trying to understand how people make sense of their world. And if you're methods are mainly interviews and focus groups, then you might be going down this route. So you're looking for the meaning in their conversation as they talk to you. Now, grounded theory, you don't really start out with any particular theoretical perspective. You build it from the ground up. Your theory emerges as you analyse your data. I'm not going to say too much more about that just now. Much applied health services research, which I think is the area that we're all in, doesn't aspire to a particular theory. It's atheoretical. And that's okay. It draws on the techniques from all these different kind of theoretical approaches. But the end product, you know, what most of us want, I think, is to see some kind of improvement in the healthcare delivery for the patients that we're interested in, which is a little bit different from a sort of anthropologist's or a philosopher's way of life. You know, we have a much more practical outcome at the end of it. Now, views are divided on whether being atheoretical is a problem or not. I don't think it is, but some sociologists and anthropologists would disagree with me. But you will have to address your theoretical perspectives at some point. Do you want to ask me anything about that, or is it okay if we leave that there and go on to the practical bits? Yeah? Okay. Just wanted to flag it up so that you know that there's an issue around that. So these are the sorts of qualitative research methods that you might utilise. Interviews and focus groups, obviously. Is anybody doing anything other than interviews or focus groups? Is anybody doing any observation, or you do?
Not in my PhD, but in part of our research.
Oh, okay. Right, what are you observing?
We're observing case management for pneumonia.
Oh, okay.
In different levels of healthcare.
Oh, okay. Yeah, interesting. Okay. I don't know if anybody's doing any consensus methods, Delphi studies. Yeah, you're going to do that? Oh, you're almost tiptoeing into qualitative work there. I mean, Delphi methods are essentially questionnaires, but there is a qualitative element in kind of trying to pull together the consensus at the end of the day. And a nominal group is a kind of focus group that does a consensus methodology as well. I don't know if anybody's doing documentary analysis or anything like that. No, okay, we don't need to talk about that. Case studies. Catherine, the PhD student I had, did a case study of this electronic health record implementation. So that involved interviewing all the key participants in a she would select a hospital ward, say, and then she would interview the doctors and the nurses and the administrators and the policy makers who were introducing this policy. She'd interview the patients about what their perception was of, you know, is the doctor always just playing with the computer while I'm trying to talk to her, that kind of thing. She did a documentary analysis which looked at the sort of history of how this policy had been implemented. And she did a lot of observation. So she would go around with the team as they did their ward rounds, as they saw patients in clinic. You know, the advantage of it was that she could ask them actually in the moment, why are you swearing at this computer, you know, and what's going on here, you know, what's the problem? Why are you writing it down in the notes and then transferring it into the health record later? You know, that's not what it's supposed to be. You know, you can sort of find out all that sort of thing as you go along. So case studies are often quite pertinent in the sort of areas of research that you're interested in. Anybody doing systematic reviews? Yep. Yeah. I mean, if your methods include some qualitative you know, if your area of interest includes a lot of qualitative studies, then what you will need to look at qualitative methodology for systematic reviews. But that's a whole other hour's talk, so I'm not going to go there at the moment, but there is help available should you need that. Action research, I think probably you're not going to engage with. It's really where you work with a team I'll give you an example, it's easier to explain it that way. One of my colleagues, Jo, is a palliative care researcher, and she wanted to look at how people in nursing homes, in care homes, are treated at the end of life, and why they're not getting a good kind of palliative care approach. So she actually worked with the nurses in the care home to decide how they were going to research that topic and how they were then going to change their practice as a consequence of the research. So action research comes very much from the participants upwards. So am I okay to talk mostly about interviews and focus groups? Will that cover your needs mostly? Okay, good. Well, just a few more examples really. These are some of the sorts of questions that you might address with qualitative research. Self-management of asthma, this is Hilary's big area. We've done a lot of qualitative work with Hilary, where we interview patients particularly about the barriers to effective self-management in their real life. Anything to do with long-term illness and particularly young people, what kind of challenges do they face in managing that sort of diagnosis. The third one's a study that I did with Scott Murray, who you might have met, one of the professors here. We knew that people with heart failure probably had less good care than people with cancer in the community at the end of life. So we did a study where we compared the experiences of people with heart failure and those with lung cancer. I always think with long-term illnesses and cancer, it's kind of a family situation rather than just the patient. So we do a lot of work with families and how illness impacts on family dynamics. And I think this last one, patient's perspective on risk versus benefit, is becoming increasingly pertinent with all the new treatments that we have available now. I find I'm getting asked a lot about this in relation to patient involvement. There's a whole lot more things we can do now that we couldn't do 20 years ago with data, with tissue samples. It's actually very pertinent to ask patients and the public for their perspectives on weighing up risk versus benefit. Just because you can know if you're at risk of a particular genetic condition, should you know? Do you want to know? If you know, what impact does that have on the rest of your life and on your family? So there are lots of very sort of complicated ethical, social questions that are well addressed by qualitative research. I think it's just worth saying that there are certain things that qualitative research can't do. If you're very much trained in the scientific background, you might struggle a little bit with some of these concepts. Qualitative research can't provide you with information about prevalence and cause and effect, all those things. It doesn't represent a whole population. You can't reduce your data to numbers. There's no point at all in saying I interviewed 20 people and 5 said this and 6 said that and the rest said something else completely different. No point at all. So the results are not statistically generalizable. But that's fine because it's not trying to do that. You've got other methods that can do that sort of thing. This just drills down to the depth of understanding that you don't get with quantitative methods. If your view of life is that facts constitute evidence, numbers and statistics, then you will struggle to get your head around qualitative research. But, it shouldn't be an opposition. Unfortunately, sometimes it is. Okay. So if you're going to do interviews or focus groups, how are you going to decide which? Well, that depends on what your research questions are, really. And also, you've got to be pragmatic, and realistic about what you can do in the time that you've got available. I think most of you have jobs. You're busy. It might be nice to interview 100 people, but your life will not be worth living because it will stress you out trying to do all that. Just remember that a PhD is your research training. You're not trying to win the Nobel Prize here. Not yet. That's the next thing. You just have to be realistic in what you can do in the time available. And, I'm always telling students, scale it back. Just think not what it would be ideal to do, but what you can actually do and do well in the time available to you. And that's how you'll learn most. You've got to think about things like what resources you've got available. I happen to know you don't have a lot of resource to support any costs that you might have. And you know, time obviously is one of your short resources. And if you've got to negotiate access to groups of patients or health professionals or hospital sites, if you need to deal with ethics processes, all these things eat into your time. So, you know, just keep it sensible. But the key issue in deciding between interviews and focus groups is, do you want an individual perspective, or is it helpful in some way to have a group interaction? You know, sometimes if you get people together, they can be a bit intimidated by having to speak in front of other people. But for other groups, sometimes the group interaction actually leads you to much better data. I'm thinking particularly of the work we do with young people. They actually seem to really enjoy getting together and talking about their mutual kind of problems and how they deal with them. They seem to find that quite supportive. So, you know, there may be times where you really want a person on their own because they think you think you'll get more that way, or you might want to think about the group interaction. But again, there are some pragmatic issues. You know, if your participants are widespread over hundreds of miles, then getting them together for a group probably isn't going to work. And you know, if you're interviewing healthcare professionals, as I have found to my cost many times, trying to pin GPs down to get them to come to a focus group is a total nightmare. It's much easier just to get on and do it one-to-one, because, you know, that's...
So, I have a question.
Yep.
Can we have a combination of independent studies and focus
Yes.
groups in one study?
Yes, absolutely.
For example, in my study, what we're doing is that we're interviewing, we're doing qualitative research among caregivers of children under 5. What I've done is, because the mothers are the primary caregivers and they have much more in-depth knowledge, we're conducting in-depth interviews from them. And the fathers and the grandmothers, we're conducting focus groups because they can give us a broader perspective of care. So is that a good approach?
I think that's an absolutely good approach, yes. So I'm going to talk a little bit more about the anaphylaxis study, and we did a mixture of interviews and focus groups for that, for slightly different reasons. But I think the thing about qualitative methods, any research methods, is you've got to justify what you're doing. So as long as there's a good reason for that, then that's absolutely fine, and I think that's actually a very good way to proceed with your sort of topic. Yeah. Any other questions about that at the moment? Okay. Okay, so suppose you're going to do one-to-one interviews. You need to decide how structured your interviews are going to be. So we usually use an interview guide. So looking at the literature and our knowledge of clinical practice, we've come up with a list of questions, and you know, we might try them out as a pilot, and we'll end up with a semi-structured interview guide. That's probably the most common way of proceeding. If you're going to have total structure, you might as well do a questionnaire, really. But semi-structured gives you a little bit of chance to shape how you want the interview to go and the sort of topics that you want to cover, but it also allows your participants to raise some issues themselves. Now, you know, we like to give some of our participants the opportunity to shape the story that they're telling us. I'll give you one example. Marilyn would probably have told you this if she was here. It comes from one of the studies we did together about lung cancer. And she went to visit an elderly man at home, and after all the sort of introductory pleasantries, they sat down to do the interview, and she said, "Can I get you to, hello, come and join us. Can I get you to start by telling me when you were diagnosed with lung cancer?" And he said, "No, I'd like to start with telling you what I did in the war." So this is a bit of a heart sink moment for a qualitative researcher, because you think, oh my goodness, that's 50 years worth of story that's nothing to do with my topic that I want to listen to. But actually, when you think about it, he was establishing himself as a vibrant young man who'd had an interesting contribution to make to life rather than as the old man with lung cancer. And I think that's fair enough, actually. So that's an extreme example, but you know, semi-structure allows you to just kind of take the lead from the patient a little bit. You don't want a complete lack of structure, otherwise, you know, they can just tell you anything and, you know, the bits of your data won't be very easy to pin down. But so semi-structured is usually the way to go. Then you need to decide how you're going to do your interviews. Are you going to do them face-to-face? Are you going to do them by phone? You can do them by email, but it's not quite the same thing. Ideally, I think probably face-to-face is best because you get all the interpersonal interaction. It's interesting, phone interviews tend to be shorter. It sort of somehow seems to be more business-like that way. And also, you're not picking up on the same verbal cues that you would be if you were, you know, looking the person in the eye. So face-to-face is ideal, but sometimes that's just not possible. I think, you know, if you're talking about really difficult subjects like somebody's experience of a life-limiting illness, then face-to-face is definitely better. And it gives you the chance to use some of your fabulous skills as health professionals as well. Phone is just a little bit more impersonal. But sometimes, you know, if that's the only way to get the data, then that's the way it is. You might decide whether you want to interview people one-to-one or in pairs or families. But you can't always impose that on the people that you might be interviewing. So when we were doing our study of lung cancer and heart failure, sometimes you would go to the person's house and their husband or their wife would be there. Are you going to say to the wife, well, would you just go out while I talk to your husband? You know, you can't really do that when you're a guest in somebody's home. And there are two sides to look at that. I mean, first of all, they obviously have the right to do that. Sometimes people do encourage each other to say more than they would if you were just talking on their own. You know, they might say, oh, well, do you remember when this happened? Or why don't you tell the nice researcher about, you know, this experience? But it can also be intimidating and inhibiting. You know, I can think of another example where the wife had cancer and she really would have quite liked to talk to the researcher about it, but the husband didn't think that she should be talking about it at all. He thought it was negative, and you know, so you can end up with some slightly difficult situations. But you know, we have to take our cue from the people we're interviewing. Really, we can't impose our will. It's the same with the teenagers. Sometimes they wanted their parents there, particularly the younger ones. We did try our best to talk to the teenagers and parents separately, but again, you can't make them if that's not what they want to do. You can interview people just one time, if that's the right thing to do, but there might be other situations where you want to do serial interviews over a period of time. So when we were doing the lung cancer and heart failure study, we interviewed the people 3 times over the course of 18 months, thinking that that would help us to understand how the situation was changing as their illness progressed and as they got more services in, that kind of thing. It's interesting. It's a lot of work. You build up a really good relationship with the participant. Our interviewer in this case was Marilyn, who wasn't able to be here today, but we actually built in some counselling for Marilyn into our research grant just because we thought she might really struggle with the kind of loss that she would experience after she'd got to know these people so well by going to their homes so often, you know, if they died or, you know, at the end of the study or whatever. And, you know, but it did give us some fabulous data. I've mentioned about the sort of structure and flexibility of the topic guide. Now, mostly you will record your interviews. I mean, is that sort of what you would see as standard practice or, yeah? Okay. I think it's really important. It captures all your data in its natural form. Gives you something to listen back to later. And what we do usually is transcribe it, so word for word, somebody listens to that tape and writes down everything on it. And maybe tries to capture things like if somebody sounds like they're crying or they're laughing or, you know, something. Now that's a lot of work. I don't know if you've got anybody to transcribe your data for you. You'll be doing it yourself? Yeah, okay. Be prepared for a long, long process, unless you're a touch typist, an audio typist. Yeah. You as the researcher are the research instrument. It's not just the interview guide, you are administering that interview guide, and it's your personality and the way that you interact with the participant that often determines how successful the interview will be. I would really recommend that you keep field notes. Those of you that are experienced in qualitative research probably know that already, but it's really good just to write down after an interview how it felt. Has anything occurred to you that might be useful when you come to do your data analysis, or that you might not have thought about before? Just how you're feeling about things, if it went well, if it went badly, why you thought that was, anything really that might be useful. And by the end of your study, you'll have a really good document about the whole process.
Will it help to note down body language?
Yes, absolutely. Yes, that's right. You're absolutely right. I mean, that can be really important, the kind of non-verbal cues that you would get in the course of an interview that you wouldn't capture on the tape. Absolutely, yeah. So. Any other questions at this point? Yeah.
I have a question about translations. Usually we will get our interviews done in the local language or something.
Yeah.
So
Yeah.
after we get the verbatims or we transcribe our interviews, when is the right time to translate it into English?
Yeah, well, it depends on the makeup of your research team. So this is a question about transcribing and translating of data. We had to do this once. We did a study, a palliative care study of people living in Scotland from Southeast Asian communities who had sort of end of life conditions. And some of the interviews were conducted in the person's own language rather than English. So we had both an interviewer and a transcriber who spoke the relevant languages, mostly. So they would translate as they transcribed, and then they would check with each other, and then they would have to translate into English before they could present the data to the rest of us. So it's a bit of a complicated process. But I guess it depends, is it all one language that you're talking about, or a number of languages?
It's usually
One language, yeah. And will all the people in the research team be familiar with that language? A supervisor in Edinburgh might not be. So, so I guess at that point you're going to have to transcribe and translate concurrently, but you also do need to get it checked. That's the other issue about that. Yeah.
So in many qualitative research, the people quote the terminology used by the participants. So
Sorry, what was the
in the qualitative research, people love to quote the statement.
Yeah.
And most often the discussion is in local language. So
Okay.
do we need to write the code both in local language and the international language, like English, or just the translation is fine?
Yeah, I mean, I think you're going to be writing up your PhD in English. So, that kind of answers your question, I think. I mean, I think it's tricky, isn't it? Because sometimes there are nuances in a local language that are quite difficult to translate into English. So it's kind of the best job you can do. But your supervisors, you all have an Edinburgh-based supervisor, I think, don't you? They're going to need to see it in English. So it's going to need to be a fairly early point, because they will want to see some of your data. And the statements that we use, we use a lot of quotes to illustrate our themes when we're writing up qualitative data. And I think if you want to publish, you'll almost certainly need to write those in English as well. I mean, am I right with that? So, yeah, I think so.
Do we
so yeah.
need to write the local?
Yeah, I mean, well,
and then both the code is in
Ideally, because really what we try to do is back translate as well. Now I know this is even more time consuming and expensive, but it would be considered good practice to translate and then get somebody to back translate just to be sure of accuracy. Sorry to break that to you, but that is kind of the gold standard of what you would normally do. So
So what is
yeah.
back translation?
Okay, so
The important conversations in the interviews or something like that. Is it okay, or back translation has to be done for?
it should be done for everything. Yeah.
I have one query.
Yeah.
When we are to do qualitative research, then we may have to do focus group or we have to do one-to-one. So how do we choose that which is the one which is best for this situation?
I mean, it depends a bit on your research questions and on your group. So what sort of people would you be?
I will be basically doing on adults with COPD and
Adults with COPD. And is it what's the nature of your inquiry? Is it about their experiences or how they take their treatment?
Experiences about the disease, experiences about the treatment, whether they know about the disease, whether they actually go for treatment, how often they go, and other related social issues that are associated with that.
I mean, I think we had this conversation just slightly before you came in, but I think both are okay. So there are two questions really. One is, what's the best way to answer your research? Your research question, do you think people will be more likely to open up to you if they're talking to you one-to-one? Or will they encourage each other to say more? Or might they be inhibited if there are other people there in talking about? It's those kinds of things. But also what's practical, because we were talking about how you've got a limited amount of time to do your PhD. If your participants are all kind of local and you can get them all together, then that's possible to do a focus group. But if there's one 50 miles down the road and one 100 miles the other way, then it's probably not going to be very practical. So those two things really. Does that answer your question? Okay.
Yeah.
Okay.
Oh,
another one. Yeah.
I was also thinking I thought okay, focus group would be good because most of them are around and they are of same socioeconomic status and all. But whether I am correct or not, that's the question. I am thinking it's good. Focus group would be the best for this type of group.
Yeah.
But will it always be correct? Maybe
Not always. I mean, I'm sorry there isn't a sort of yes or no answer. It's kind of an it depends answer. But if you think that the people would come together okay, would discuss the issues that you want to discuss freely, that they might perhaps encourage each other to say things that they wouldn't say one-to-one, then it's fine. Yeah. So, okay.
Okay, thank you.
Okay.
I have one just
Oh,
question.
okay.
In this in-depth interviews,
Yep.
forgot.
Maybe we can come back to it.
No, I remember. I just forgot.
Should we come back to that one? Or?
Yeah, I think
Yeah.
we should
Okay.
come back.
Fair enough. Right. Okay.
Would you be talking about quality checking?
Yeah. I can talk about that. Yeah. Have you got it? Yeah. Okay. Let's have it then.
So, for example, if we are doing focus groups, then we usually take some themes which we already know of, and then depending on that themes, we try to ask questions.
Yep.
And sometimes we also get something from them. And
Exactly.
We frame the.
Yep. That's
the
absolutely
framework.
fine. Yeah.
For in-depth interviews, do we need to do in a similar way or?
That's exactly what you would do. So you will have your interview guide, whether it's for a one-to-one or for a focus group, which you will base on some of the things you know from the literature, maybe some of the things you see in your clinical practice or what have you, some of the unanswered questions. But you always have the flexibility to add something that just comes out of maybe some of your early interviews, some good idea that somebody tells you that you'd never thought of before, and you think, oh, I need to ask everybody else about that as well. So yeah, it's what we call an iterative process. You can just keep adding as you go along. Okay?
Yeah, thank you.
Good. How many of you are health professionals? Nearly, no, most of you. Okay, you have quite a lot of these skills. We hope. I'm sure you're good at what you do. You know how to create rapport, how to encourage somebody to tell you things that maybe that are difficult for them to talk about. You'll be familiar with the concept of active listening, where you're not just taking in what they say, but you're taking prompts, you know, something that they say prompt you to ask a question that you might not have thought of otherwise. Trouble with health professionals is that, you know, we're very short of time and we're used to having like maybe 10 minutes for a consultation or something, so we're always taking shortcuts, trying to get the most information in the shortest possible time. A research interview is not like that. It's much more open. And so we actually really have to kind of practice quite hard, I think, as health professionals to not do what we would normally do and to give people space, to really make sure that our questions are open questions and not questions that just invite a yes/no answer. We need to be picking up on the cues that people give us, probing a little bit, asking them to clarify something that's maybe not clear. You know, it's a slightly different set of interpersonal skills in a clinical interview and a research interview. The other thing that we're very good at as health professionals is problem solving. You are not in a research interview to solve anybody's problems, you know, you just want them to tell you about their problems. And it's, you know, a real temptation when we're trained to see how somebody might benefit from a particular thing, to avoid yourself saying that in the context of an interview. You know, but you really have to fight that impulse. You know, it's actually quite important that you're in there not as a health professional but as a researcher. It's difficult sometimes. Very occasionally I have intervened if I've seen something that I just think this person shouldn't be living like this. I might, you know, go and talk to their doctor or something and say, you know, I've just seen this person and they haven't got enough food, or you know, they haven't got any money and whatever, and you know, something might happen. But you know, we really have to try and resist the temptation to give people advice. We do have to try and keep people on track. You know, it's all very well letting people have a free rein to kind of talk about what they want to talk, but we do need to get our research questions answered. So you have to try and find a way of doing that in a nice way that doesn't make them feel rejected, but guides them back to the topic in question. Managing emotions, well, that can be you and that can be them. You know, sometimes we just see things that are actually really pretty distressing. You know, and it's how you manage that. I've got a PhD student at the moment, Anne, who's doing interviews with the parents of children who died from an asthma attack or had near-death experiences and survived. And it's so emotional. And I think, you know, you have to kind of work out your own way through that. Is it okay to be emotional with the person? And so she quite often can't help herself from crying, you know, just because they're crying and it's all very distressing. But, you know, it's just about managing all that sort of things. Obviously, we have to try and be aware, and this is where reflexivity comes in as well. We've got to not lead people down a particular path looking for an answer that we want to hear. Judgments, you know, we can all be very judgmental about behaviours that we don't agree with. And we're also not there to disclose anything much about ourselves, I think. I'm not too rigid about that. If somebody, you know, if I'm in a conversation in somebody's house and they ask me some questions about myself, then I might answer some. But I'm not going to volunteer a lot of my feelings and experience because I don't think that's relevant. So that's all about reflexivity and being aware and writing down in your field notes if you come across these kinds of difficulties and show how you dealt with it. Now I've got an example here from our anaphylaxis in teenagers study, just to give you a sense of what qualitative data are like for those of you that haven't seen it before. It's the sort of depth that you go into. Now, this was an interview with a parent. Now, we know as health professionals, one of the things we know is that we train parents and teenagers up to administer their adrenaline in an emergency situation. This is what is likely to save their lives. But in an emergency situation, hardly any of them actually do administer the adrenaline. So we needed to sort of try and find out what's going on, that despite all our wonderful training, they're still not able to put that into action. And this is what this mother said, talking about her teenager who'd had an anaphylactic reaction and she hadn't been able to administer the adrenaline. So she said, "I hope I never ever have to do this again. It was the most frightening experience I've ever lived with. I knew how to do it. I didn't know if I could actually do it or not because I was absolutely terrified. He was screaming, I was shaking. I thought, oh my God, what's going to happen when I give him this? That was my fear, that I wouldn't have given it properly, he could have died. If I didn't do that right, how could any parent live with themselves knowing they never gave their child that? It's total panic. Panic in my case, and when you panic, the kids panic even worse. I was confident that if I ever had to use it, I would know how to do it. But when it actually occurred, I just total froze. I just thought, oh my God, I don't know if I can do this. I literally thought, oh my God, if I do this wrong, my child could be dead and it's my fault. I mean, I haven't even begun to convey any of the emotion that was involved in this scenario, and this went on for a lot longer than this. But, this is just an example of the sorts of ways that qualitative data can really help you to understand what's going on in a situation that seems fairly straightforward. If we train people well enough, they will be able to administer the treatment in the real life situation. But then you see all this going on, the fear, the panic, the terror, the feeling that if you do it wrong, you might kill your child instead of save them, and you begin to understand, well, just teaching them how to inject adrenaline into an orange probably isn't going to actually meet the mark in this sort of case. So just a little example of where qualitative data can be helpful. Okay, so focus groups, that's obviously something of interest to a few of you. I think really don't choose it as a method just because you think, oh, well, that'll save me doing 10 individual interviews if I get them all in the room at the same time. It doesn't really quite work like that. It's doing something different. You can ask people questions in a different way, I think, when you're in a group rather than one-to-one. You probably have to do far more in the way of facilitation and management than you do in a one-to-one interview, because you've got to kind of stop certain people dominating maybe, or encourage the quiet ones to speak out. But what I've found with doing focus groups is that other members of the group will ask questions of each other, things that I might not have thought of. So you get a different kind of interaction in that way, and that's actually quite good. I think it's probably less good for sensitive subjects. Anything that people might find embarrassing to talk about, maybe group work isn't the way to go. But the interaction can actually be very useful in terms of people kind of questioning each other about their attitudes or their behaviours, sometimes trying to work out solutions to a problem together. It's quite creative. And as I said before, we found that young people actually do quite like focus groups. You've got to decide what kind of makeup. Yeah, sorry, do you want to ask me a question now?
So when we are doing focus groups as an interviewer, should we allow other people to talk among each other? Or?
Yeah, I think so. Yeah, so the question was about whether participants can talk to each other. I do think so, and I think that's actually one of the advantages of a focus group rather than an interview. It means that not all the power is vested in you as the researcher, it's kind of shared out amongst the group a little bit. And I think, they will come up with questions that either you might feel a bit awkward about asking, very direct questions sometimes, or just good things that you'd never thought of. So yeah, I think it's to be encouraged. And I think that's actually one of the main advantages of a focus group as opposed to a one-to-one interview. But yeah, so you have to decide whether you want kind of similar people or whether you want a kind of range of people to present a different set of views. And that's kind of, again, it depends on your group. You might want a mixture of men and women. A mixture of ages maybe doesn't always work so well. And we've even found with teenagers that sometimes we need to separate out the 12, 13, 14-year-olds from the 17, 18-year-olds because they're so different. So you might want a number of focus groups of people with different characteristics, or you might want to mix them up to you. 6 to 8 people is usually fairly manageable. You can have more, but it gets harder the more people you've got in the room to kind of keep a lid on it. Make sure that they introduce themselves to each other and try and set some ground rules, I think, for behaviours. It doesn't usually get out of hand, but just occasionally you can get a difficult character. Sometimes we find that having some structured activities helps, particularly with young people. We might get them to do something that involves some drawing or some making some diagrams of something, or something like that, just to kind of break the ice a little bit, make people feel a bit less awkward. Yeah. Any other questions about that? Yep.
Sometimes you invite your participants 6 people, but maybe 2 only turn up. You still call it a focus group?
Yeah. Okay, I've done focus groups that had as few as 3 in them, and at the end of the day, I might have invited more, but sometimes people can't make it. I think if anybody turns up, you might as well just interview them, partly because they've taken the trouble to come along anyway, but also you can still get some valuable data, and then you might want to go out and collect some more. I tend to usually invite more than 6 or 8, just knowing that some might not turn up. It's probably just a little bit of insurance.
But you still call it a focus
Still call it focus group, absolutely, yeah. I mean, sometimes, when we were doing the anaphylaxis study, we had a focus group with school nurses, but there were only 3 of them, so, in the whole of Lothian, so, it wasn't ever going to be any bigger, but I would still call that a focus group, yeah. Anything else? How are we doing for time? Okay.
Just a basic question. Why is it called a focus group? Is the focus on the group or
The focus is on the topic, I suppose, really. It's a topic about a focused discussion about a particular topic, I think, yeah. So. It's kind of been taken over a bit by marketing people. It's not, it's not my favourite term, but that's what it is.
When we are doing a focus group, along with the interview, female persons can be.
Sorry, can you just repeat it?
Like when we do a focus group, along with the interviewer, there can be another 2 persons in a team who act as a recorder and observer.
Yeah, I think it's good practice to have more than 1 person in the room if possible. One of the advantages of having a second person, you might give 1 person most of the responsibility for leading the focus group, for doing the interviewing bit, but having somebody else there that's kind of observing what's going on is really helpful. Keeping an eye on the non-verbal stuff, or how people are looking and feeling, maybe coming up with some other thoughts that you hadn't thought of, somebody else that can worry about whether the recorder works and whether the tea and coffee's arrived, and all that sort of thing. It's good practice to have more than 1 person, I think, yeah. So I mean, obviously your core skills, I think, are pretty much the same as for your interviews, except facilitation and moderation in a group-like way, and managing the individuals in the group if you get anybody particularly difficult is the thing. So just a few more practical tips. It always takes more time than you think it will, so be generous when you're doing your timetable. Any qualitative researcher will tell you from bitter experience, make sure your tape recorder is working, because sometimes you press the wrong button, or the batteries are flat, or something else has gone wrong, and you've collected all this wonderful data and there's nothing there. I think when we're doing focus groups and interviews, we need to think about where is the best place for the person that we're interviewing. Sometimes that might be going out to their home, sometimes it might be the clinic, or whatever. Noise, now that's a tricky one. Quite often we've found in people's houses that there's a washing machine going and that's all you can hear on the tape when the secretary comes to transcribe it, or there's a dog barking, and if you can do anything to kind of manage that, that would be fine. I once did an interview in a cafe, which was a lovely interview, but it was punctuated by beer barrels being delivered outside and dropped onto the pavement with a great clang, so, you know, just one of those things. And I think also look after yourselves a little bit. Give yourself some space. Try not to schedule one interview followed by another one immediately. Just give yourself a little space to walk away, think about it, come down from it. If, you know, if it's been really successful, you get a bit of a buzz, you know, a bit of a high, and it's really nice feeling, and you just need a little bit of time to gather yourself up before you go on to another one. Also, if it's an upsetting topic, just enough time to go away and have a cup of tea or talk to somebody about it and just make sure you're okay and your mind has dealt with that one before you go on to the next one, because you won't give your best to the next interviewee if you don't do that. We do have to think about our own safety, particularly if we're out there doing one-to-one interviews. Make sure somebody knows where you are and what time you should be back, and have some kind of way of checking back with somebody to make sure that they know you're okay. You're not on your own in this, you know, you hopefully have lovely supervisors who will give you excellent advice and support, discuss everything with them, whether it's one-to-one or by email or on the phone, and write absolutely everything down. It's a tremendous record when you come to analyse, write up your project, if you've written everything down in your field notes, and you know, maybe keep a reflexive diary if you're interested in that. It's just so helpful, because what you're doing when you're writing up is showing how you made decisions along the way, and if you've documented those decisions, it's so much easier than having to think, why did I decide to do that? So, you know, I would really, just some very practical tips there for that sort of thing. Now, sampling in qualitative research is different from quantitative research, but you've still got to be systematic about it. That's really important. Again, there is no right and wrong way of doing it. It kind of depends on your topic and your questions and your participants. But you need to define your population first. So if that is adults with COPD or asthma or whatever, then you're probably wanting as diverse a group as possible within that. So the way to go really is purposive sampling. Now, what you would do then is look at the patient population and think, well, on average in my country, how many men should I have compared to women with this particular condition? What's the kind of age profile of patients with this condition? You know, what kind of socioeconomic groups might I want to look at? Do I want to look at rural, urban, mixed kind of areas? And then you're seeking as diverse a population as possible within that. So you will have a sampling framework where you can say, right, well, ideally I want 10 men, 10 women. Of those 10 men, I want so many within this age group, so many in that age group, so many from that socioeconomic group, and so on. And then start finding your first people, and then you'll kind of know who you're missing. So if your first 5 people are all women from a sort of fairly wealthy area, then you know you're going to need to go out and find some men from you know, a less or a more deprived area. The easiest thing in the world is to do a convenience sample where you just take the first 10 people that come across your clinic door or whatever, but it's not a very good way of getting the diversity of views that you need, so I would try to avoid that, particularly for a PhD, because questions will be asked if you go that way. And for a qualitative study, again, it depends. I mean, I think most of the studies that I've done, we've had something like 20 or 30 participants. It might be more. You know, especially if your main method is focus groups, you can probably include a few more people. And anything up to about 10 focus groups, depending on what kind of methods you want, really. Anything you want to ask me about that? I haven't gone into that with a lot of detail, mainly because it's going to be quite individual, depending on your own project, so your supervisors will guide you. Not really, no. Snowballing is where you, I mean, we have done snowballing, particularly, trying to think which study we did snowballing with. I think it might have been one of the anaphylaxis studies where you recruit somebody as a participant, and then they might know somebody else who might be able to provide you with good data. So we've done that a lot with health professionals who, you know, we might recruit one expert and they will say, oh, well, you ought to ask that other expert, they'll be able to help you. That's actually quite a good sampling method for certain circumstances, yeah.
Could you
Yeah.
combine the
Yes, absolutely. Yeah, definitely. I mean, I think, you know, purposive sampling is just a good way of making sure that you've got the breadth of participants that you need. But certainly you can have a bit of snowballing within that as well, absolutely, yeah, yeah. Oh, you next, then you.
So when you do purposive sampling, you also want to consider the maximum variation in terms of the group.
That's right, yeah.
So would it be like consider like equal number of men and women or different age groups? Or?
Well, that depends on the condition, because, you know, you might have something where there are just simply more women than men with that particular condition. So you might want to have rather more women in. You know, there might be age groups. I mean, when we were looking at heart failure, the age profile was, you know, pretty much 60 upwards, with a predominance of women in the sort of over 85s, because they're the ones who survive longer. So we had to kind of just tailor it a little bit to that. And we had the odd person with a really unusual kind of profile, who was maybe a bit younger or had a slightly different variation of the disease. So, you know, it's kind of individual depending on the profile of, you know, the population profile of that particular condition, I think. Does that make sense? Yeah. Same question, right, okay, excellent. Yep.
Often it's said in qualitative research, you sample till you...
Data saturation? Yeah. That's right. It's a tricky concept, data saturation. It refers back to that notion that I mentioned before, where you might think that you're going to recruit maybe 30 people, and then you find after 20 interviews that you're not really hearing anything new. So in that sense, you would say that it's saturated. You're not going to learn any more by conducting any further interviews. Can you ever say that? You know, when you're talking to humans, you know, your 21st person might tell you something completely other. So I think it's a concept that's got to be taken with a little bit of care, shall we say. But, you know, you might well find that you've covered all the main themes without necessarily fulfilling your original intentions, and that's perfectly okay theoretically, yeah. So, but just be careful with it. I think it's a bit easy sometimes for researchers just to say, oh yeah, we've achieved data saturation. You think, Sometimes I read papers thinking, I'm not sure about that, but it's actually on my next slide. Where's my wee pointer? So, okay, we've covered a lot of this, but you know, the data is transcribed verbatim, so every word, every funny things people say get written down, but you anonymize it as you write it up. That's really important, ethically. You start your analysis in qualitative research really from the minute you start collecting data. So rather than when you do a questionnaire and you wait till you've got all your questionnaires in and then you analyze them as a bunch, with qualitative data, you start looking at your data as soon as you've collected it, because you might start to identify some themes, some new topics, some other things that need to go into your interview guide or whatever. So that's why it's an iterative process. You're continually feeding back into it.
So what you do is that you, like if you want to do interviews, then you wait for some time and analyze that and then continue the rest.
I'm going to talk you through the process a little bit more in relation to a particular study. But what I would do would be listen back to the tape as soon as I can, sort of in a few days after the interview, and just start to write some notes while hopefully somebody else is transcribing it for me, because it would take me forever. And then once I get the transcript back, I read through it and start making some notes about things that I'd like to pursue maybe with other people, maybe some additional questions, perhaps some early ideas about themes, some really kind of interesting words that people use to describe something, whether that's worth pursuing with other people, and then you just build on that as you go up. And then once you've got your whole data set at the end, then you do that systematically, either using a computer program or not, depending how much you've got and how you feel about that, really. So coding is the process where we start to identify themes from our data and draw it up into a kind of framework. I think what I should do probably... No, I'll go through this and then I'll show you the example. So we're looking for similar things across the interviews, so themes that people have in common, but we're also looking for differences. So, you know, we have to be quite systematic about it. Sometimes something jumps out of the data at you and you think, that's really interesting, and I'm going to pursue that. And then nobody else says anything like it. So, you know, you've just got to kind of have some weights and balances in there. You can use a computer program to assist you. It does not do the analysis for you. It just helps you to organize it. So the ones probably that we use most around here are In Vivo or Atlas. You may have other ones that you're familiar with. But it doesn't do the thinking for you. It just helps you to collect all your data around a particular theme in one box, if you like, that you can then pursue later. And again, there are so many methods of analysis. It depends on your study design. I can't really be too prescriptive. It's kind of individual. But I think you would probably start with two things, a content analysis and a thematic analysis. And if you've got different sources of information, so in our case we had the teenagers, the parents and the health professionals, then you'll want to start comparing themes and differences across those as well. So this is the kind of process, an initial reading, and getting familiar with the words that people use, the phrases they use to describe what's happening in their lives. You know, you start to get your first categories and themes together. New categories occur. By the time you've been through your whole data set one time, you should have a nice list of the sort of categories and themes that you're finding. And then you go back all around it again, looking to see if that's confirmed in your whole data set. So when you're doing a thematic analysis, it's a much more in-depth exploration of these themes. And you're constantly comparing across different interviews, different cases. So a case in our case would be the teenager, the parent and the health professional. You're constantly comparing across those things. And you're going back to your whole data set and examining it in the light of your new ideas. You might be sharing this with your supervisors who might have a slightly different interpretation and give you some more ideas. But your process should be transparent to others. How you've arrived at the themes should be transparent. So let's talk about this in more depth. It's quite hard to talk about theoretically, but hopefully an example will help you. So with teenagers and anaphylaxis, what we wanted to know was what knowledge and understanding do teenagers, their parents and their health professionals have? How do they perceive the impact of this life-threatening thing on their life and well-being? And what are their risk managing strategies? And also, because we know teenagers take more risks, you know, they go out and they eat foods that they shouldn't be eating and blah, blah. Why? You know, what is it that's leading them to take those kind of risks that threaten their lives rather than being maybe socially different to their peers? So we had 26 adolescents and we interviewed 28 of their parents as well. We then took our initial findings about their experiences, their risk management strategies, the sort of things they did to help themselves, the sorts of damaging things they did to themselves. And we presented those data in a preliminary sort of analysed format to some focus groups. So that's why focus groups and interviews in the same study can be quite useful. And we try to use that to find ways of saying, well, what recommendations can we make for practice that are going to improve the lives of these teenagers? So this is how we went about our data analysis for this. Hopefully this will make the process a little bit more transparent. So our researcher, Michael, read all the transcripts and made notes. And he drew up an initial coding framework based on our initial ideas from the research questions, the emerging themes from the data, and the key idea from the literature. And we ended up with something far too long and unwieldy. It had 70 codes, and that was just far too many to work with. So Michael and I worked together to edit that down and refine it into something a bit shorter. And then Michael went back and reread all the data with the new coding framework to see that we'd got everything together. So we analysed the data from the teenagers as one lot. We analysed the data from the parents as another lot. And then we looked at them across the families. And we identified both themes, the things that they had in common, and things that kind of disagreed with that, what we tend to call disconfirming data. So you can have one great idea, but maybe a couple of people say something completely different. And I read all the interviews independently, and then independently coded 10% of them using Michael's coding framework, and then we conferred. So this is what a coding framework looks like. So you've got your kind of top level, level 1 codes here, and sort of slightly more separate codes there. So for example, auto-injectors. I mean, these are the injectors, the EpiPens that the teenagers carry with them. So we had a whole code where every mention of auto-injectors or EpiPens was put in that particular box. And then we had examples of how they manage their anaphylaxis using the EpiPen, whether their family and friends are kind of involved in the management with their EpiPen, have they trained their friends up how to administer the adrenaline in an emergency or what. And also because we were particularly interested in teenagers, you know, teenagers are moving from being dependent on their parents to manage their anaphylaxis risk to having to manage it themselves. So that was a really important area. So we had a code that was all about that.
So level 1 and level 2 codes, what's the difference between them?
Okay, so these are kind of higher level ones. So auto-injector is a top level code. So you would have, I don't know, do you use a particular coding computer analysis? Yeah, okay. So you would group together everything where auto-injectors are talked about from your research. And then you will have some subgroups here where you collect together, so that's everything about auto-injectors. Then in that, there's everything about how they get them and how they're prescribed, how they're trained, how they carry them. So it's kind of just more detail on certain subtopics. So these are things that are talked about regularly by almost all your participants. Okay.
So these codes are based on the experience or previous literature?
These are based on the data. So you read your data and you say, everybody talks about auto-injectors, so obviously that's the top level code. And then you look at how they talk about their auto-injectors. So some of them are talking about why they carry them. Boys don't like carrying them because they don't have a handbag and it spoils the line of their jeans if they put them in their pocket. You know, that kind of thing. So everything that's about why they carry them or why they don't carry them goes in that box. And that's the theme. And then you've got chunks of your raw data that you've put into this particular file in your computer. And then you can read through that and say, well, these are the most important things here about this. Trying to think some of the, we know that they almost carry their auto-injectors. What we found from this study, they carry them in some way thinking it's going to protect them, almost like having a lucky charm, but they can't actually deliver it when it comes to the point. You know, that's one of the things we found. So, you know, you would collect all the examples of that sort of thing, and then you can write that up as a theme and use some quotes directly from the participants to illustrate that theme. You got that? Yes? Yeah, okay.
And how do we try to reduce the subjectivity in coding? Because usually I might feel that, okay, these are the codes which are coming up from the data, but he might feel something different.
Yeah, I think that's right. I think, well, there's a few things about that. Partly it's about being aware of your own biases and letting the data lead. So it's the data that leads you, always. But that's why the supervisor checks a proportion, a kind of random sample. And then there will always be some differences. They're not usually conflicts. They're usually just, perhaps, you know, your interpretation enhances something, and so you can have a nice discussion and it makes the whole thing more robust. So reflexivity, letting the data lead, and having a sample checked by somebody else. Yeah. So anything else on that? It's the key thing really to qualitative research, is making sure that you've analysed your data well.
Sometimes I find it too hard to remove bias.
You can't remove it. You can't. I mean, you know, people will tell you can, but you can't. You know, we are all products of our backgrounds and our training and our experience and our beliefs. You just have to be aware of it. You know, just try and be aware of where you might be influencing things, and be prepared to have your beliefs challenged. You know, something that you believe might not turn out to be true from the point of view of these teenagers. So, you know, that's kind of...
I think the point which we said earlier, data leads the way.
Yeah.
We should not lead, means we should not think in our way. We also look back and see what the data says.
Exactly. Always keep going back. Yeah. I mean, it's difficult. You know, we all have views and we all have ideas about what we think would make a difference, but yeah, we just always have to keep going back and back. So every new idea, you go back and check it with the data, make sure it really does say that. And some of your favourite things, some of your favourite quotes, you will never be able to use because, you know, it's just one person said that, and, you know. We're out of time. So I will just skip over. I mean, I had just given you a little bit of information about another study that we've done, but I won't talk about that. You can read that up. Just a word about writing up. It's a long way down the line for you, but really what you've got to do is explain the process. There isn't a right way and a wrong way to do any kind of research, really. Sometimes it doesn't go according to plan, but you've got to be able to justify what you've done. Okay, so if you did it for all the right reasons and it didn't quite work out, that's okay. You know, you've just got to make that decision trail really clear. And tell your story in a sort of clear and concise way. You know, you are distilling a volume of data like that into a thesis like that. So, you know, I think it's one of the hardest things. We all overwrite and then have to try and distill it down to the essence. But you've also got to present enough raw data with qualitative research to illustrate your themes. So some really pertinent quotes are really important. I think this point is actually one of the really important things. Make clear exactly what comes straight from the data, what's your interpretation of the data, you know, and just be really clear what the difference is between those two things. At the end of the day, you know, your last chapter is going to be about, well, what have you found that's different from what we already knew? Did we find anything? You know, some things will support what's already known, some things will be different, some things will be new information that helps to improve things going forward. So, you know, those are the sorts of things you need to think about.
So while writing up, is it important to write a quote for each theme?
You need to have all your strong themes included in your findings, but there are some that you might think, you look at and there's nothing much in there. I think generally speaking, I would say yes, try and encompass all the main themes. But there may be some that you don't need to spend a great deal of time on because you just haven't found very much out from them. So, difficult again to be too prescriptive, it depends what you find.
When you present your codes, sometimes English is not the first language.
Yeah.
So when you present the codes, should you make it grammatically correct, or because if you
Yeah.
change, if you make it
I know.
grammatically correct, you actually lost the meaning.
I know.
Yeah.
I know exactly what you mean. And we have this in Scots as well, because, you know, there is English and there is Scots English. So the long quote I gave you from the mother of Kevin, who's, you know, panicked and froze, it's not grammatically correct, but we did translate it slightly into English because most people have to understand it. When we put that in a journal, it has to speak to the English-speaking world. And in fact, we've had journal editors say to us, can you take the Scots out of that and put it into English, you know. So, sometimes we do, sometimes we don't. But yeah, I mean, it's a tricky one. But I think, you know, you've got to make it understandable to your reader at the end of the day. So yeah. Okay. Yeah, so just my final thoughts, really. You know, as I say, don't be too ambitious, keep it manageable, don't stress yourselves out any more than you need to. You know, have a read of what somebody else has done. You know, read a qualitative thesis, read a few journal papers with qualitative methods, and you'll soon get the hang of how you actually write this up if it's new to you. I know you're getting the chance to talk to some other PhD students, some of whom will have used qualitative methods. They are probably your best friends this week, so talk to them. And you know, there's loads of help there. You can always ask for help when you need it. So, you know, I think even if you're not using qualitative methods for this particular study, it's an important thing for you to know about, part of your toolkit. I am biased, of course, but I think, you know, qualitative methods are what we need to help us improve healthcare. We can have all the best ideas in the world, but if we don't know how the public perceives these situations, what the treatments are on offer, what it means to them, then there's no chance of changing anything about the way they behave. Yeah.
How do the scientific world or academic world now view the evidence that comes from this qualitative research?
That's a very thorny question, the evidence base for qualitative research. I mean, I think, you know, we were talking about it earlier, that people who are very much trained in the scientific method do find it difficult to say, well, why should we take notice of what 20 people said and change anything on that basis? But you're looking for some explanatory power from qualitative research, I think, which is the value of it. You know, it might work in a number of ways. You can do some preliminary qualitative work to inform a large-scale trial. But there are sometimes examples where qualitative research on its own is enough. I mean, I can think of a study we did about out-of-hours services in palliative care that did actually change practice because, you know, the services were running from 9 till 5, Monday to Friday, and weekends were terrible for some of these patients at the end of life. And the GPs actually introduced a palliative care service that covered the weekends as a result of some of the research that we did. So, you know, it's a different kind of evidence, I would say. But you will always find people who disapprove of qualitative research because of the small numbers. Its depth is the thing.